Hi, this is Tom Luescher and Inside Cardiology. Today we talk about a very old drug, the beta blocker. But there's new evidence that allows for a more personalized use of these medications in different cardiovascular conditions and different patient populations. And that's the topic. But let's go back in history. And here you see this nice, friendly gentleman called James Black, later Nobel laureate for the discovery of propranolol. And his idea was to find an analog of adrenaline to block the activity of the sympathetic nervous system that increases blood pressure and heart rate. And he came up with a lot of compounds, and eventually this one, propranolol, appeared to be the one that had antagonistic effects on the beta receptor, on any beta receptor. Of course, as you know, it was not selective in nature. And then this was, of course, first thought to be a drug for angina pectoris. At that time, there was no stenting, there was hardly any bypass surgery, so mainly medications for patients with chest pain upon exertion, as you see here from the classical net or schematic. So you can see here an old publication in 1974 in Drugs showing different beta blocker compounds, and propranolol was the most efficacious because the exercise time was prolonged the most of all these 5 compounds tested. So it worked in angina pectoris, as you would expect. It lowers heart rate, it lowers oxygen consumption, it lowers the activity of the sympathetic nervous system, so you can, of course, exercise longer without pain. And then they discovered here in this seminal paper in Circulation in 1968 that in fact propranolol works on blood pressure, as we would expect, because it blocks adrenaline that increases blood pressure. So it was discovered as an antihypertensive drug, and ever since beta blockers are used in hypertension to lower blood pressure. They're not the first line drug today, but they are effective. They lower blood pressure and heart rate. And then people thought, if you have an acute myocardial infarction, the most important thing to reduce infarct size was to reduce oxygen consumption in the context of ischemia. And so they developed the BHAT trial, beta blocker heart attack trial, published in JAMA in 1982 by the investigators. And here on the left you can see the first results of this randomized trial with placebo at the time and propranolol, and there was a substantial reduction of mortality, particularly also sudden cardiac deaths because of antiarrhythmic effects of beta blockade in this context. And then, of course, new drugs were developed, drugs that specifically would block beta-1 receptors or even would have some vasodilator effects and so on as well. So this is, of course, the history of the ACS management. At the time, there was defibrillation, there was beta blocker when they published the BHAT trial, and then, of course, there was the discovery of balloon angioplasty by Grunzig, as you can see. But later on, only in the early 80s, was there the first stent implanted, and it took a while then to show that, in fact, balloon angioplasty, and particularly stenting of occluded coronary arteries, was life-saving and massively reduced mortality that you see here depicted. And today we're up around 10%. So since the BHAT trial, there was massive change in the management of acute coronary syndromes or acute heart attacks, and therefore we have to reassess the use of beta blockers in this context. In fact, today many patients come so quickly to a primary PCI that they hardly have any change in left ventricular ejection fraction, unlike in the old days. And so, first of all, after BHAT, it was shown that beta blockers against intuition were actually good in patients with heart failure. And there you see in the middle, besides, of course, ACE inhibitors and mineralocorticoid antagonist beta blockers, in this context, carvedilol is a beta 1 and vasodilator beta blocker, markedly improved survival in patients with severe heart failure, all ejection fraction below 35 or lower. And then, of course, other compounds were tested, bisoprolol and other cardio-specific beta blockers in CBIS2, also with, again, a significant effect on survival, and eventually also metoprolol in several trials showing cumulative mortality being reduced very significantly so. So beta blockers are established whenever you have a reduced ejection fraction of 40% or less. The question is, what happens for those who have mid-range ejection fraction or even normal ejection fraction? And so the first meta-analysis looking at more recent trials that you show here, Reboot, Betami, Danblock, and Capital RC, they showed, they looked at patients that had an ejection fraction of 40 to 50%, so mid-range reduction. That is relatively common now in patients that have an acute heart attack, particularly those that come a bit later to the primary PCI. And they showed for the primary endpoint a clear signal for improvement with a p-value that was a bit borderline, but clearly the curves separated early on for the primary endpoint, so it's mainly non-mortality events because all-cause deaths, as you can see on the right,